Hi everyone, this is Dr. Akash Mittal, final year PG resident from the Department of Radiology from East Point Medical College, Bangalore. I would like to extend my thanks to IRIA for providing me this opportunity to present a rare case at the 25th MRI Teaching Program. I would like to extend my regards to Dr. Kaleem sir, Professor and HOD, and Dr. Anand sir, Assistant Professor at my department, who helped me and guided me in formulating this rare case report. Abstract. Differentiating gastric malignancy from inflammatory pathology becomes challenging in the presence of overlapping imaging features and adjacent organ involved. Here we are reporting a 42-year-old male patient who presented with epigastric pain, dysphagia, and weight loss. On imaging, the picture was of diffuse gastric adenocarcinoma with possible focal pancreatic tail involvement and cystic findings which mimic inflammatory pathology, therefore posing a diagnostic dilemma on the CT. Introduction. Gastric cancer is a major cause of cancer-related mortality, with diffuse type adenocarcinoma posing a diagnostic challenge due to its infiltrative growth, which often mimics inflammatory conditions. CECT suggests malignancy, but differentiation from reactive pancreatitis at the gastric pancreatic interface is challenging, and the cystic changes can mimic pseudocyst, which needs careful correlation. Coming to the aims and objectives, the aim is to differentiate gastric malignancy from inflammatory pathology on imaging, particularly in complex cases with adjacent organ involvement. And the objectives include identifying CT features of malignancy, differentiating benign from malignant conditions, evaluating the gastric pancreatic interface, and correlating the imaging with endoscoping and HPE findings, and also a brief in understanding the role of imaging in staging and the management. So, a brief on clinical profile. A 42-year-old male patient presented with the symptoms of epigastric pain and progressive dysphagia to solid foods. There was significant weight loss of up to 12 kgs in the last 1 to 1.5 months. The patient was recently diagnosed with diabetes with an HbA1c of 8.6, and there was no associated history of vomiting, hematemesis, or altered bowel habit. The patient is a non-smoker with no alcohol abuse history, and the family history revealed an unknown malignancy in a second exit clinic. On the initial non-contrast scans, we observed diffuse, nodular, circumferential gastric wall thickening from GE junction to the pylori, and additionally, a cystic appearing lesion was seen abutting the posterior gastric wall at the splenic height. The pancreatic tail appeared bulky and showed peripancreatic fat stranding and thickening of the anterior pararenal tail. The cystic focus raised multiple possibilities: a gastric diverticula, a complicated ulcer cavity, or a pancreas-related cystic lesion. These imaging findings further warranted characterization. Following IV contrast, the gastric wall demonstrated long segment, irregular asymmetric thickening, and mild homogeneous enhancement. The cystic lesion, however, remained well defined and lacked enhancing solid nodularity. There was loss of normal neural stratification appreciable as enhancement of all the layers throughout, irregular inner margins, and the thickness of the wall measured up to 21 mm. The perigastric fat along the fundus and proximal greater curvature showed significant stranding with linear soft tissue streaks and tiny discrete nodules. These were seen radiating from the serosa. And the liver enhanced normally with no focal hypoattenuating lesion. No obvious metastases were seen in the visualized lung fields and in the adrenals. Coming to lymph nodes, there were multiple oval subcentimetric lymph nodes along the drainage pathways in the celiac, superior mesenteric, and perigastric region, showing homogeneous enhancement. Then the enlarged lymph nodes were also seen in the supradiaphragmatic region with the short axis of more than 6 mm, and they demonstrated suspicious round morphology. The cystic lesion at the greater curvature appeared fairly well defined, smooth, regular walled, with fluid attenuation and measured around 2 to 4 centimeters, and all these showed peripheral homogeneous enhancement. These are the coronal reformated images, and they clearly demonstrate the gastric cyst splenic interface showing indistinct smudged margin with close apposition. And given this indistinct interface, T4B disease remained a possibility. The patient was recalled and positive oral contrast was administered with ROI kept at the stomach, and the findings corroborated with the CECT findings of asymmetric circumferential gastric wall thickness. Notably, there was no contrast or pacification within the cystic structure, and it effectively excluded communication with the gastric lumen. This critical finding shifted the diagnosis away from the diverticula or ulceration and supported the rare possibility of diagnosis of gastric intramural pseudocyst. So, overall imaging features favored malignant etiology over the inflammatory pathology, as we can see in the table that the characteristic in our case of irregular asymmetric wall thickness, loss of normal neural stratification, infiltrative fat stranding, and suspicious nodes were more in favor of malignancy than just the reactive wall thickness. The most likely diagnosis was given as diffuse type gastric adenocarcinoma, and differentials were labeled as gastric lymphoma, severe hypertrophic gastritis, and less likely but metastatic. Biochemical follow-up showed serum lipase to be mildly elevated at 456, and upper GI endoscopy showed growth at the fundus extending from the GE junction and the continuation of the root circumferentially. Note here is to be made that this cystic lesion was not visualized on the upper GI endoscope. This highlights the complementary role of CT in detecting extraluminal or perigastric pathologies that are beyond the field of endoscopic visualization. While endoscopy evaluates the mucosal surface, CT assesses the full thickness of the gastric wall and the adjacent structures. On biopsy, signature cells and pools of mucin were seen, which confirmed adenocarcinoma. Also, there was acute inflammatory infiltrate. A brief on American Joint Committee AGCC TNM staging, where T1A represents tumor invasion into the lamina propria, T1B tumor invades into submucosa, in T2 into the muscularis propria. In T3, the tumor penetrates the subserosal connective tissue without invasion of the visceral peritoneum, whereas in T4A, the tumor invades the serosa, that is the visceral peritoneum. And T4B, tumor invades adjacent structures such as spleen, transverse colon, liver, and etc. M0 is no distant metastatic disease, and M1 represents distant metastasis along with distant nodes. So, end staging, we follow Japanese Gastric Cancer Association lymph node station. And in our case, there was a supradiaphragmatic lymph node, raising the possibility of distant nodal spread. A brief on stage-wise treatment. For stage 0, we follow endoscopic resection. Stage 1A, surgical resection is done in the form of subtotal or total gastrectomy with D1 or D2 resection. For stage 1B to second, there is perioperative chemotherapy with surgery. For stage 3, that is a locally advanced stage, neoadjuvant chemotherapy followed by gastrectomy and D2 lymph node resection, again followed by adjuvant chemotherapy. And for stage 4, that is the metastatic disease, systemic therapy is given with palliative surgery or stent. So this case highlights a complex diagnostic scenario with suspected gastric malignancy occurring alongside focal pancreatic tail pancreatitis, underscoring the importance of careful radiological and clinicopathological coordination. Intramural gastric pseudocyst remains an exceptionally rare entity with fewer than a dozen well-documented cases worldwide, the largest recent series being a 6-case study from PGI. So to conclude, diffuse gastric wall thickening with loss of mural stratification strongly favors malignancy. Perigastric fat stranding and lymphadenopathy supports malignant etiology, and fat plane loss at the gastric pancreatic interface is not a reliable sign of invasion. And associated findings such as pancreatic enlargement or cystic lesion can mimic inflammatory pathology, and at the last, histopathology remains the gold standard. These were my references. Thank you.